Hello, everyone, and welcome to this week's COVID Insights. This week, we'll be discussing the issue of quarantine with some new guidance out from the CDC. I'm Fred Goldstein, and joined today by our great group of physicians. So, why don't you please go ahead and introduce yourselves? Start with you, Luis.
Yeah, I'm Dr. Saldana, emergency physician, career emergency physician, who's worked also in technology and digital health as well, and all things now and all things COVID.
Hi, and I'm Dr. Nick van Terheyden. I'm also an emergency room physician and focus on incremental improvements for better business, better health.
Well, fantastic. This week we got some new guidance from the CDC regarding quarantine, changed up some things. I know there are a lot of questions and some confusion, so perhaps first we could start with what is the guidance that came out of the CDC this week? Who'd like to hit that one?
Why don't I start? So the CDC has issued, updated information based on the risk profile of the disease, and in particular the potential for an individual that is suffering from COVID-19, such that the risk of them spreading infection decreases as time goes by. And the old guidance was requiring them to stay in quarantine or isolation for 14 days. The new guidance allows for people to come out of that or not to stay in for as long without testing at 10 days. And if they're able to test, to come out at 7 days, and they're deemed to be not a risk to other people for spreading COVID-19. So essentially we've reduced from 14 down to 10 possibly, and even 7 days. So that's a potential halving of the period of time that people have to spend in isolation or quarantine.
And what was the reason really that we're seeing for this shift?
Yeah, so I think the reasoning is in part driven by the challenge that everybody is having. 14 days, that's 2 weeks, that's a long time. That's especially long in US terms, given that most US employees don't even take 2 weeks holiday. For the Europeans, they all take 2 weeks holiday, but here in the US, we don't. So asking somebody to isolate for that extended period of time takes them out of commission, and in particular from a work or economic standpoint. So it increases challenges. And there's also, in certain circumstances, depending on how people are isolating, if they're self-isolating or they're using their own facilities, less of a strain. But if they're being put into quarantine accommodation, then that takes up resources, and you've also got to get food to them, do all of these things. That just extends the challenge. So I think it's as much about the economic burden, balancing economics and risk appropriately with the updated information in terms of the transmissibility of the virus over the course of time.
And I know, Luis, that when this first came out, I think there was a bit of an uproar from some providers. And so there was then sort of a pullback. What's your sense of that and your feeling as a physician regarding the change to the guidelines?
Well, probably, Fred, I think I would say long overdue. I think because if you think about other guidance that has been updated from the CDC, it's a pretty long time that this went out there and has stayed out there. And the original 14-day recommendation was based on kind of the upper bounds of the incubation. And so, in other words, that was a very conservative take at that point in time, early going into this pandemic, really before it got to the kind of level that we're at now. I think this takes a look at data. They have data that they've looked at. And like Nick said, also, I think you're weighing three things: risk of transmission by shortening. But why would you shorten it? And Nick, I think, explained it well. The burden economically and otherwise, and then compliance. I think the idea is this will increase compliance with that if you're not going to be out, 2 full weeks as far as that goes. And one thing I will point out is that these were put out by the CDC as options. In other words, they offered two additional options, a 10-day option, that is 10 days, kind of even independent of testing, which says after 10 days you go out. The risk that they say about with that over the 14 days, it seems fairly small increased risk, maybe 1%. There is some upper bounds up to 10%, but really a pretty small increase in risk. The second option is a 7-day with a test. In other words, with a negative test. The challenge there is the logistics around scheduling the test and getting that done for that 7-day period to take effect. The risk profile with that, even with the negative test, is still higher. They estimate about 5% increase risk as far as that goes. So I think you look at those, and I think the different groups will have different takes on this, and how they leverage this. County health departments, colleges like we work with, other businesses potentially, and things. But really, much of it's going to be driven by whoever's doing the contact tracing.
Mm-hmm.
Yeah, I think it's important to highlight that one of the risks, as you rightly point out, Luis, is these are people that are considered contacts and therefore at risk, and an assumption that they're positive, they have COVID-19, even if it's an asymptomatic. So how do you get that test? We're not bringing tests to those individuals, so then they have to come out. So there is some risk associated with testing out. And I think it's important that there are options. Generically, I'm supportive. I think, reducing the burden and trying to increase compliance, I think, is important. But where possible, I'm certainly, on the conservative side of saying, extend it to the full 14 days. That reduces the risk, not down to zero, because there is almost no such thing, but it really diminishes it as much as possible. So taking the lowest risk, or the lowest possible acceptable risk in your particular circumstance, given the environment that you're in.
Yeah, and I will say one other thing quickly is that what's discussed in their guidance is the PCR test. So they're recommending the PCR test because you're at least you're around 7 days post exposure, potential exposure, and they feel that in that case the PCR test, and based on looking at numbers, they thought that is the way to really lower the risk. So I think if you did any other form of testing, you might raise that risk even more.
Yeah, they do actually classify or make assumptions. They assume that the sensitivity for the antigen test was 70%, and obviously with the PCR much higher. So it raises it by about a percentage point, but they're relatively small numbers. Yeah. At the 10-day, it's almost just a percentage increase if you move to antigen testing. So again, minimizing, and some of this is dependent on availability. One of the things that we're challenged with PCR is you've got to go to a lab, you've got to have the amplification process and the temperature baths and all of that. The antigen testing is, potentially something that might be possible to actually get to the individual and have done in situ, as it were, which, whilst that's slightly higher risk, it also means that there might be some compliance around that. So maybe over the course of time, we might see, more antigen testing as a possibility.
Mm-hmm. And my sense of this is you have to test between day 5 and 7. So then the question becomes, have you gone to a place that will give you a turnaround within that period of time, or you're just going to be in there longer anyhow, right?
Right. That was one of the things. In fact, they actually make note of that the testing, within 48 hours, so 2 days of the point in time, but taking account of delay. And I actually heard just today on the radio that testing times have increased to 3 to 4 days. And of course, that starts to diminish the value, because if you've gone 3 to 4 days backwards, that's no good at all. It has to be later. And ultimately, if the testing time gets long enough, you might end up spending 14 days waiting for your test.
Yeah, exactly. When you hear people's experiences about getting their results and their PCR tested, it often is that. So that'd be my concern. The other concern is the logistics of, okay, so I'm in quarantine. I'm going to go drive over to the test to get my testing done. So I think I'll go stop by in the restaurant and pick up a burger or something. So again, that's why to me it seems like the 10-day option seems to be the probably the better of the two when you just look at all factors.
Yeah.
And one thing I'm not sure there's an answer to, I don't know if either you can answer this, is the way I read it, it sort of pushed it to the local public health departments as to whether or not they wanted to do that. So is it feasible that an employer group within a community says, I'd like to do a 10-day with my employees, and the public health department is contact tracing them for 14? Monitoring their quarantine for 14 days?
I think it could be, depending on the size of the employer. Obviously, we're working with colleges, and colleges I think have work with their public health department. I think what's happening there is that they're working with their local public health department and saying, we have the capability to do this or that, or enforce the quarantine. So I think some certain companies, say healthcare companies, or hospitals and things, I think that you can look at getting you have to get folks back to the workforce. And we've seen places around the world where they return people to work when they're positive, and so that we know they've tested positive. So I think in those cases are going to be special instances where it's not all going to be the public health department that's doing that. They may have their own internal contact tracing and management of infection. Certainly hospitals have their own infection controls that usually manage all of those from my own experience.
And I would say that, in lieu of any specific guidance, I would always make the point consulting with your local state and county regulators, being in close contact. I think people appreciate that. We've certainly seen that with our clients, close discussions and coordination, so that there's no opportunity for misunderstandings, and more importantly for people to fall between the cracks and think that they're complying but they're really not. So I would encourage that communication early and often.
Great. Any other comments on quarantines, or if anyone has any questions, please feel free to put them in the Q&A or the chat box, and we'll get to those. One of the things I also thought we might get to this week is we've obviously got some vaccines pretty close. We had a question submitted in the registration about different types of vaccines. Do you want to address a little bit of that, one of you, or both of you? What are the different types?
Well, so why don't we talk about the two that, there's three. So categorize them. Moderna and Pfizer are the messenger RNA virus methodology, both of which require low temperature, one more so than other. The Pfizer requires a much lower temperature that requires special freezer capabilities, but they both work on the same principle of messenger RNA that induces an immune response. And then the AstraZeneca Oxford virus vaccine, which is based on an adenovirus that has been modified to produce or present the COVID-19 molecules so that the body induces an immune response. We've done that type of vaccination capability with other vaccines. Pfizer is available and is being distributed in the United Kingdom. Went to the First Lady, I believe, yesterday or the day before, and the second gentleman. It's interesting, mostly we remember the name of the first person, but in this case, I'm remembering the name of the second. It was William Shakespeare. Of course, the Brits would no doubt pick on that. And I believe the FDA meeting is tomorrow. for approval. So we could start to see, and I know they've already staged it. So those are the three, and I'm sure that we're going to start to see more. And we've already seen the data. I've seen the data on two. I've seen the AstraZeneca data, or at least the report on it, and the Moderna. I've yet to the Pfizer. I've yet to see the Moderna publication, but that's coming up soon.
Mm-hmm. Was there anything you saw in that, Nick, that stood out different from the initial press releases that were very limited in terms of what they said?
No, I think they were on point. There's been a lot of focus around the AstraZeneca trial and the fact that I think it was the Italians that got the dosing wrong and gave half doses. What I found interesting was it seemed that that had been communicated well ahead. So it wasn't this was a surprise at the end of the trial as they were sort of publishing. They had communicated that to the regulators and had dealt with that in the ongoing assessment, and in fact proved to be serendipitous because it showed us that you could get a much higher, north of 90% efficacy in the case of a lower dose in the first dose. Relatively, I would say, in terms of numbers, very small numbers of severe reactions. I looked at all of those. They were spread across the two arms, and I believe in all the cases deemed to be not vaccine related or unlikely to be vaccine related. And there were some deaths, but these deaths were split across both arms, and they were general deaths that you would expect in a population normally. And I'm not saying death is normal, but you see that if you grab a group of people, a large group of people, you're going to see people dying, especially if they're across a large age spectrum. It was predominantly cardiovascular disease that they died of, myocardial infarction, and I think it was 2 and 2 in the placebo arm and in the vaccine arm. So nothing that really jumped out. In fact, I read it and was super impressed with how much efficacy that they got in the two arms of the trial. Side effects, the one surprise to me was there was more of the, I want to say mild side effects. I don't want to diminish how severe they can be, but the flu-like symptoms, sore arm, fever, aches, pains, those kind of things seem to occur more frequently in the younger age group than in the older age group, which I wasn't expecting. But maybe that's because our immune system has seen so much more stuff by the time we get to be older that we're a little bit better able for the vaccine.
Mm-hmm. And Luis, there's been a couple of just blasted headlines recently on those two cases in the UK who got it with an allergic reaction. Thoughts on that?
Well, yeah, we don't have all the specific details, but I do think Pfizer has kind of responded and said they're recommending that folks that have had a history of allergic reaction to vaccine or especially anaphylaxis not get it. As far as that goes, at least at this stage in the game. But I wonder if you still can with kind of informed consent as far as that goes. I'm willing to accept that risk. I think that that's always a risk. I think we see that in anything that some folks are or have a higher incidence of anaphylaxis. And, I think in these cases, I even saw maybe both of the patients were patients that carried EpiPens for anaphylaxis anyway. So they were already probably at higher risk. So you're selecting a group of that. I don't think that it's going to be a big issue overall. I think they probably might have similar reactions to the flu vaccine. It'd be interesting to see if you had that data and ask them what vaccines they had reactions to before.
Makes sense. And there's an interesting comment in here, a really good one actually, from Mary Beth, who says she does case investigation, and the cases are very reluctant to provide close contact information so that they can notify others and explain their quarantine requirements. We've sort of seen that varying rates around the country. I think there was one article that talked about 74% of the people were unable to be contacted or unwilling to share cases. So any thoughts on that whole issue?
I would say we've seen that certainly in the data and the experiences with some of the clients that we've been working with, including a diminishing return over time. where people are less and less inclined to share information. Um, much of this is behavioral and also a trust issue, and consequences. So if I declare this, am I then, is there a punitive association as a result of sharing contacts? Am I perceived to have misbehaved or done something incorrectly? I mean, I think that's, if I was to sort of highlight the one approach to this that really makes sense, it's the same thing that we do in medicine for M&M, morbidity and mortality. Root cause investigation, same as the airline industry does, with zero fault approach. And, I know we're imperfect at that. We always seem to look for fault, but it's not a fault to drive to an individual and, be punitive about it, but to learn from that mistake. And we need the same thing with contact tracing, but, that's a trust issue. And we seem to have broken a lot of the trust, unfortunately.
Mm-hmm. I
Yeah,
know there was.
I'd agree with that around the trust. I think it's also goes to something I've seen with folks that I've known that have tested positive for COVID is there's even a reluctance to report or share that information with the folks so this kind of falls really along that. It's all I think there's kind of this sense of a stigma attached to I had COVID, like you said. Some of it is the fault, this kind of fault. Well, I did something wrong, and I think we really have to as Nick said, eliminate that. You're not at fault here. Or we're trying. The goal is for us to try and curtail the spread of this virus and things. But we definitely have heard that. I think in terms of what Mary Beth shared, and I think we have seen it be better actually at one of our college clients. I think they're a little more willing now. Have they had full disclosure? Probably not. I think it's always probably going to be partial disclosure. I did see an interesting thing, and I wish I had the reference to or the link to this, about doing it in a different style and actually having folks go back and think about go back, and it's almost like putting yourself back there and think about this and stuff. And kind of a very it's kind of a very different than rather than kind of a sterile approach to this. It's a little more interactive and things. But right now, certainly, are these folks that are doing these case investigations are slammed, and it's difficult to deal with just the sheer volume of this.
Mm-hmm.
And the experience and the expertise around that. It's interesting. The contact tracing course, that I went through, just from an informational standpoint, a big chunk of that is about open-ended questions, psychology of sort of approaching this, and how you. I forget the terms. I mean, I'm certainly not an expert at that, although that's one of the things that we try and think about in medicine, to try and be open-ended in the way that we approach it. I want to, just before we drop off and leave the quarantine, I want to get back to that for a second and talk about sort of quarantine. Imagine if it's a family member that's getting, gets a contact notification and says, "Hey, you are a contact," and they're living in a shared family household. One of the challenges, how do you deal with that? And I actually think you've got some good insights on that, Fred, because you've essentially done that, not from a contact tracing, but in terms of how you go about quarantining in a sort of home setting.
Mm-hmm. Yeah, I've actually had to quarantine two people in the house, as one of them, when they came out of the state of New York early on in Florida, was requiring 14 days. And the second, when somebody left and had an exposure and had to quarantine, and we said, "You're going to quarantine here." So there were some simple things we did. I mean, we were lucky. We have one room in the house that has a separate back door. So we had them actually come in. They both actually arrived in the evening at night, and they went straight into that room, and the room had been already prepared: refrigerator, microwave, towels, showers, plastic bags, food, popcorn, you name it, to make it reasonable and then it was really about how to just ensure that they had what they need during that period of time, and we really minimized our access to them. As a matter of fact, I never saw them except once when they were outside, each when they came into the backyard out that back door during the 2-week period. And the second time we made some differences because there were more issues around airflow and things like that that had become part of the bigger thing. So we looked at that as well. But you would think about if you've got somebody coming in your home, you may want to, if they're arriving or something like that, just clear it out, not be there, let them get settled, then come back in, clean the place up quick, and really figure out how you're going to get food and other things to them. I know the universities have done a lot of work on this, obviously, and been very successful at it. So it was an interesting experience and worked well. I would like to add 1.2 back to the other issue is that this whole thing on contact tracing. I know Berkeley had an outbreak that they wrote about in the summer with the frats, and they essentially recognized early on that they would not get a lot of great response from the students, and they really talked to the students about just calling the people anyhow and telling them what they need to do. And they shut down an outbreak that started with about 47 people, and kept it from getting any bigger. And I think a lot of that was due to the students themselves self-notifying who they didn't want to make public to the contact tracers. So it's just something to consider when you're doing that.
Yeah, I see Mary Beth talking about some of the experiences that they've had, and trying to make it and facilitate it as much as possible, offer free at-home testing, which I think is a great idea. But I think you're right, Fred, that capacity to sort of provide the onward information for contact tracing so that somebody can action it. It reminds me very much of the STD slips, the paper slips that people would hand to you. It had all the information and it was essentially anonymous, although you could tie it back to the original distribution point based on the codes on the back if you needed to. But from an action standpoint, it gave people something that they could do locally. So, maybe that would help from a contact tracing standpoint.
Yeah, I'll throw in one other thing that's certainly a huge barrier on this, and that's the folks that are kind of essential workers, or we look at the social determinants of health, the folks that live can't you can't put somebody in a separate, you don't have a separate place, everybody has to live in the same small area and things like that. So I think those are challenges, and those folks certainly don't want to they need to go to work. If they don't go to work, their family starves, and we know about the issue with food insecurity and things as well. So I think this whole challenge has really shined a light, or shown a light on these social determinants, which I think has led to the discrepancy we've seen in outcomes, the haves and the have-nots. And I think that's and I think that's a factor, is some folks just can't do what they're asked to do, and things for very practical reasons.
Yeah, that points to the need has been brought up a few times more recently about perhaps, and really we should be doing this for those individuals who are in that situation. If they're food insecure, et cetera, we should be supplying that. Figure out a way to get the food to those folks in the house. Figure out a way to help them out in that building they're in, and deal with the issues. If they've got a shared bathroom or something, providing them with information and resources so they can effectively try to minimize the risk of staying in that house with somebody who's quarantining. And I think maybe it's something we'll look at.
Before we close, I just want to quickly pick off the question from Erica. I think, great point, this issue of quarantine and isolation. Isolation is for a positive test. So you've received a COVID-19, you've got COVID for all intents and purposes. And quarantine is you've been in contact with somebody, but we're not sure. And you're absolutely right. I would even hold up my hand and say I tend to sort of blend those two terms, and they are different. They do have different meanings. We shouldn't do that. Everybody from the top down, tends to use them interchangeably. If there was a positive around the CDC guidance, it's bringing the two quarantine and isolation durations into line, because again, there was some confusion around that. But you're right, we should be better and more on top of accuracy of terms. So thank you for highlighting that, Erica.
Yeah, I'd like to thank you too, because I was supposed to bring that up at the start of this and ask Nick to explain the difference between the two. So Erica, we really appreciate it. If you'd like to host this show next week, you're more than welcome to do it. So if there are any other questions out there, we'd be happy to address them. It looks like we're coming up on the half-hour mark here. We'd like to thank everyone for joining us. It's been a pleasure, and we hope you join us again next week. We'll let you know as soon as we can what the topic will be, and thanks again for joining us.